Women's Health and Contraception. Welcome to your last mini lecture for the course for the semester. We are almost to the end. So let's talk about a couple of high points, specifically regarding women's health. So here are some statistics. So maternal mortality, as we discussed before, is the death of a woman during pregnancy or within 6 months or 6 weeks, of the end of the pregnancy, regardless of how that pregnancy ended, not related to accidental or incidental causes. So the maternal mortality as of 2018 for the US was 17.3 per 100,000 overall. And this has been a steady increase over the last 3 to 4 decades. Racial disparities are present in these statistics. So the maternal mortality rate for Black women is 41.1 per 100,000, whereas for white women, it is 11.8. The most common causes of maternal mortality are infection and sepsis, hemorrhage, or cardiovascular disease. Cardiovascular disease would include preeclampsia or hypertensive disorders, as well as heart disease and other things that fall into that category. Maternal mortality is highly influenced by comorbidities. And we know that that's one of the reasons that the maternal mortality rate has increased so steadily over the last few decades, is we have an increased number of comorbidities overall in the general population. And we also have an increased number of women who become pregnant and stay pregnant or are able to get pregnant who have more comorbidities than they did, say, 50 years ago. So all of those things influence the maternal mortality rate, but as healthcare providers working specifically with this population, it is our job to combat those rates any way we can. So there are a lot of things called care bundles or national initiatives, specifically right now aimed at hemorrhage and hypertensive disorders, to try to really standardize our care as much as possible when we identify that these things are problems, so that we create better outcomes overall. Infant mortality is unfortunately very similar in that as of 2018, so we had 5.96 per 100,000 live births. Infant mortality is termed death of the infant prior to their first birthday. Neonatal mortality would be death of a live infant prior to 30 days of life. This rate is a little bit lower. It's in the 4-point range. However, racial disparities also exist in these statistics. Black babies at 11.11 per 100,000 births, whereas white babies are 4.01 per 100,000. Now, these are statistics for the US as a whole. I will say I am on a community work group that is working very hard to combat infant mortality, especially in Butler County, where we all reside right now. Ohio is very poor out of the 50 states on the ranks of infant mortality, and Butler County is one of the 3 worst counties in the state for infant mortality. So our numbers are actually well above that 5.96. Leading causes of infant mortality are attributed to congenital malformations, which we can't always do a lot about, premature birth, and maternal complications of pregnancy. Knowing that those last two, premature birth and maternal complications, are so highly indicative of infant mortality, we have done research that shows prenatal care is our highest impacting intervention in regards to combating infant mortality. The key to that, or the goal, or the reason why that is if a mom has adequate and routine prenatal care. A lot of times we can identify complications early on and treat and manage those. We can identify who is at an increased risk for premature birth and implement interventions to prevent that. The more premature a baby is born, the higher risk for poor outcomes. So even if we say find a mom who is at increased risk for preterm labor at 28 weeks, and we only get her to 32. 32 is still premature, but a 32-week baby has a much higher chance of survival and a lower chance of lasting negative outcomes than a baby born at 28 weeks. So every day and every week matters. And prenatal care is our most effective tool in identifying those underlying issues. Switch gears and talk about a little bit of the different roles among women health practitioners. So familiar with our OBGYN, so care for all types of patients, are all well prepared to do so. Some are more experienced with high-risk patients than others, depending upon where they provide care, the population that they provide care to. There are some who are more experienced in the care of high-risk patients. So a lot of times, if a patient is deemed high risk and their practitioner does not feel that they have all of the means necessary to provide them with the best care, they will refer them to somebody who does have more experience with a high-risk patient. A lot of times that involves maternal fetal medicine groups who specialize in high-risk patients and take care of those types of patients all the time, just because they are more up to date, more knowledgeable, and more experienced with caring for patients with those needs. A certified nurse midwife cares for low-risk pregnancies of mostly healthy patients, and they collaborate with physicians. In the state of Ohio, the regulations are that a CNM has to have a collaborating physician to provide care. Other states allow CNMs to have much more autonomy, in which some they don't have to have a collaborating physician. So that is very state dependent. But nurse midwives do help with delivering a baby. Flip side of that, women's health nurse practitioners also collaborate with physicians very often. They provide more primary care focus. They do not deliver babies, but they are the advanced preparation of RNs, specializing in that care of women and women's health issues. So they work more in primary care offices. And then women's health clinical nurse specialists. These are probably the least percentage out of women's health practitioners. The clinical nurse specialist used to be a much more sought after role. And we've seen over the last 10, 20 years or so that has kind of delineated into either nurse practitioners or midwives. But clinical nurse specialists provide direct care, consultations, a lot of leadership, management, and collaboration of care. They are not primary care, more inpatient acute care focused, and some have really focused heavily on research and promoting best outcome for women in the inpatient setting. So primary care of women's health, if we're talking about the primary care setting, what does that look like? What are the goals? So health maintenance and promotion and preventing of illness long-term is a very, very large goal of women's health. Routine screenings and recommended therapies. For this, think about pap smears and mammograms and all of those pieces that are specific to women. Management of social influences, eliminating disparities in care, hopefully making sure that their patients have access to care. If there are barriers in them either accessing care or executing the care they need. For instance, a great example of this would be, let's say the patient they have transportation and they can make it to their appointment, but then the physician, writes them a prescription for a medication and they don't have the means to pay for that prescription at the pharmacy. That's a discrepancy that needs addressed. So that's just one example. Screening for intimate partner violence, human trafficking, and other issues that we know are a higher risk to the female population. Family planning and infertility. So planning for children, managing pregnancies and care and deliveries, and then managing or assisting with infertility issues as those become more and more common in the general population. And then coordinating care between different areas of care, especially because no position in healthcare operates in a silo. We have patients that see 4 different doctors a year and then need a specialist or a referral out to something else, and all of those need to be coordinated. So a lot of times that falls within the primary care realm. And then family planning, contraception, or STI prevention. These are all things that need taken into account when educating patients on the options available to them for family planning or contraception, and influences that we need to consider and discuss with them when helping them make the best decision of what's right for them. A great example of this would be, if we have a patient who has 2 or 3 children, her and her partner have decided they do not want any more children. She doesn't want to undergo permanent sterilization. She's not a good candidate for oral contraceptives because she has a history of blood clots and high blood pressure. And then we have to figure out what's the best option for her for a long-term contraception. For her, it might be an IUD because those are not contraindicated with certain disorders, and it's a long-term fix with very minimal effort. IUDs are good for upwards of 10 years, depending on which one is chosen, et cetera, et cetera. If you have a patient who is, let's say, low income, does not have a lot of dispensable income or ability to access birth control, they want something that works well for them. All of these different things, cost, effectiveness, the ability of the patient to utilize the contraception effectively. For instance, the pull-out withdrawal method, or coitus interruptus is the technical term, that is not super effective. It is more effective if it's done correctly, but teenagers are not very effective at using that method. So that would not be a great, sorry, I got interrupted. That would not be a great choice for that patient. A lot of patients have very influential religious ethical influences to where, you know, this is not, some methods of birth control aren't an option for them. So that limits their choices to different things. All of these influential factors need to be considered in helping a patient and or the patient and their partner decide what is the best method for them. We are going to go into more detail on all of those in class, but that gets you kind of thinking in the right direction of some of our women's health content.